Hello everybody and welcome back to Emergency Medicine Quest. In today's video we will be talking about opioids toxicity. Before we continue, make sure to like, share and subscribe to the channel for more such content. Let's talk a bit about opioids itself. So we know that it is derived from the poppy plant. Some of the commonly known opioids are morphine, codeine. It is also the world's oldest known drug for sedation and analgesia. However, in today's context, opioid is a commonly abused drug with its related fatalities on the rise. Heroin is actually the most common street preparation, but recently there's also a surge in use of fentanyl, which is a bit of synthetic opioid. Now, among the many problems we have with this illegal manufacture of opioids, a common problem is contaminants that are added during the manufacturing process or additives that it gets adulterated with. Most commonly used are sugar, starch, talcum powder, which are benign. But on the other end of the spectrum are heavy metals, spore forming infectious agents. Opioids are generally well absorbed from GI tract, IV tract, IM tract, subcut, even intranasally. But the toxicity is most pronounced when it is ingested. Regarding its clinical features, so these patients present with CNS depression, respiratory depression, and meiosis. Meiosis because it acts on the mu receptor of our body. Respiratory depression because it tends to act on the medullary respiratory center and causes its suppression. Other than this, we can also see lung injury, pulmonary edema, and it manifests with hypoxia, desaturation in a patient. There are other signs that we need to be aware of, which is bradycardia, hypotension, pruritus. Now, hypotension, pruritus, and flushing generally occurs because of histamine release. We also see nausea and vomiting and GI involvement. Particularly, these patients have decreased GI motility, leading them to be constipated. Now, there are certain opioids that we need to be aware of because of the properties and because of the way they tend to present in people. So, meperidine is an opioid and it manifests with seizures. Methadone, the most commonly known side effect is QT prolongation. But these other drugs, methadone, fentanyl, tramadol, it can also lead to something known as serotonin syndrome. Regarding the diagnostic testing, there is no one test fits all sort of a thing because there is no reliable lab or drug screen for opioids. But in these patients, we can do ECG and, as we said, to look for any QT prolongation. If we hear that these patients have any rails, then we could think about acute lung injury and we could order a chest x ray. Hypoglycemia. This is the only presentation that is most consistent with all opioid toxicity. Now, I will take my time to reiterate over here that urine drug screen is not a reliable and not a recommended test. It can be falsely positive in many places and falsely negative. And because if it's falsely negative, it does not mean that we need to stop suspecting opioid toxicity in a patient. If we talk about the management of opioid toxicity, ABC, which is the mantra of working in emergency department. This takes precedence. Remember that these patients generally will come with bradypnea, with very low RRs, might be on the verge of a respiratory and hence a cardiorespiratory arrest. They may come with very low GCS. So be mindful of their ABCs. Now, in toxicology, we have general three principles. This applies to beyond opioids. We have three principles of treating any patient that comes with toxicology manifestations. One is we decontaminate them. Now, this could be a physical decontamination or this could be an invasive decontamination. Next, we get their body to eliminate whatever they have ingested via enhanced elimination. And third is if there is an antidote. So, these are the three principles that we follow in toxicology. Now, for decontaminate in context of opioid toxicity, prior activated charcoal was recommended, whole bowel irrigation was recommended. Today, both of these practices have actually fallen out of favor for opioid toxicity and do not have a role. But some institutions, based on their local guidelines, may still continue to give activated charcoal to some select patients. There is no role of enhanced elimination when it comes to opioids, mostly because it has a very large volume of distribution. So there's no clinically effective technique that helps with elimination. Regarding antidote, we do have an antidote, and that is called naloxone. Now, naloxone is a drug that very rapidly reverses any opioid toxicity. It can be given IV, it can be given IM, it can be given intranasally, inhalational, even via ET tube. All being said, the most commonly used and the most effective is IV. Now, the dosing for naloxone is generally in the range of 0.04 to 15 milligrams. The idea is whenever we're giving naloxone to somebody, we start them on the lowest dose or the lowest, safest dose and we titrate it up. Unless there is a cardiac arrest, in which you can consider starting them on 4 milligrams IV. Okay, but if they're chronic abusers of opioids, the best starting dose is 0.04 milligrams. The onset of action of naloxone is almost less than 2 minutes, and it's a very safe medication in general with excellent safety profile. So if you have a patient that has a suspected opioid toxicity, you should give naloxone without any second thoughts. Having said that, if you're giving a patient naloxone, the parameter that we're looking at that tells us that the patient is improving or is responding is not their GCS, is not their blood pressure, is not their heart rate, is actually their respiratory rate. So that is what should go up. If that goes up, that means the patient did have opioid toxicity and we have rightfully given them naloxone. Now, let's say that the patient is obtunded, they are bradypneic, we are suspecting opioid toxicity, we've given them naloxone, we've almost maxed out with our dose, or we've given them repeated doses, or even started them on infusion, but the patient is not really getting better in terms of their RR, then we have to consider other sorts of toxicities. Disposition wise, if the patient regains consciousness, they can be selectively monitored for a while. But if any patient had a very severe overdose, or he or she received multiple doses of naloxone, or required naloxone infusion, or required an ET tube placement. All of these are criteria for a patient to be admitted under ICU. This brings us to the end of this lecture.